Hello and welcome back to Unacademy. So let's get NEET PG. Myself, Dr. Muskan Chaudhary, and we'll do the question answer round for the Myxovirus and we'll complete the Myxovirus today. So starting with Unacademy, we get access to both the live and the recorded sessions, and you will be assessed to recorded sessions. Just to record the sessions anytime and anywhere, personalize a learning experience with highly uh, competitive quizzes that are being provided by the Unacademy. I learn from the India's topmost educators. Now assess up to 25,000 of the MCQs with high yield MCQs and clinical questions, and benefit from the exclusive chance of watching the classes on the bigger screen with printed and the digital notes that are being provided by the Unacademy. And Icon Subscription Unacademy has come together with the Prep Letter. So Clinical Integrated Essential with video lecture QBanks and rapid revision snapshots with 22 Dream Notes. Live batches, recorded classes, QBanks of 25,000 MCQs, competitive T&Ds, and the printed and the digital notes. Now, under NEET PG, that plus category, for 24 months, it will cost us around 1,500 per month, and 1625 for 18 months, and for 36 months it will be 1250. That will costing us around 36,000. For icon subscriptions for 2 years it is around 2438 per month, 1875 for 36 months, and 18 months it's 2875, costing a 58500. And please do use code that is Muskan 10 to get 10% of the discount. Now, raise a hand feature, that is something unique to the Unacademy, where you can raise your hand in the live class and can ask your doubts, can do the polling for the answers, and engage into one-on-one interaction with your favorite educators. Around 25,000 MCQs based on latest examination pattern and detailed explanation Academy has provided. Now, special class features include the live classes where you attend the live class, participate in the live chat, get your doubts cleared, respond to the polls for a better understanding of the topic, and raise a hand, talk to educators, and never miss a class because you will get the notification for the same to download the lecture notes anytime and anywhere. All right. So we discussed about the properties of the Orthomyxovirus, virus, and the Paramyxo. In the Orthomyxo, we have the influenza A, B, and the C, and we remember the mnemonic of the segmented viruses. That is the O, as is the Orthomyxovirus. That is a segmented. And what is the importance? That is HA and the neuroamidase are present on the different spikes in case of the Orthomyxovirus. Then we have the influenza virus. That is we are talking about the Orthomyxovirus, and we had the influenza A, B, and the C. Most important one, that influenza A is the most common cause of the outbreaks and epidemic, and it is the only cause of the pandemic. Then we have the rarely seen B and the not circulating now, that is the C. What else we remember, that antigens influenza causes both the HA and the neuroimmunase antigens. Then we currently circulating strains, that is swine flu, that is H1N1. Other swine flu strains are H1N2 and H3. N1. Now H2N2, H5N1, that is the avian flu and the type B. Then we have two types of changes in the influenza, that is the drift and the shift. Drift is the gradual change, while shift is what? A sudden change, explosive spread occurs in the influenza type A virus. Then we have the clinical features, that is incubation up to 72 hours, reserved for other animals, and affects all the ages of both the sexes. Most common manifestation influenza is what? Mild flu-like illness, and most common complication is what? Bacterial pneumonia. Then we have viral pneumonia and the Race syndrome. Now, the amniotic cavity inoculation by the influenza ABC and allantoin by only A. Vaccine, we have the killed and the live both, and in the trivalent, that is both systemic and the local immunity. Now, treatment was the amantadine. Now, avian flu, it is the only bird to human transmission. Human to human transmission is not there. And drug of choice is what? Tamiflu. Now, H1N1, that is H1N1, H1N2, and H3N2. They are what? They are the this swine flu strains. Now, high risk groups are the children and more than 65 years, and the drug of the choice is the same, that is the Tamiflu, and resistant to Pentadine. Then we discussed about the mumps. We discussed about the mumps, that is the most common cause of parotitis. And what type of parotitis it is? It is bilateral, more common than of the unilateral. And the most common presentation is the parotitis. And parotitis is also non-suppurative. Alright, and that is what bilateral more than unilateral, than it also calls epidemiology, that is unilateral, more common than of the bilateral. Secondary attacks rate are high in case of the measles and the mumps, that is up to 85% we have. And incubation period is important here to remember, that is 19 days. Alright, humans are the only host. Humans are the only host, and the patient are the only source. There are no carriers. There are no carriers. So, just like chickenpox, once infected with the mumps, you will get the lifelong immunity. Transmission is by the saliva and the droplet infection. And vaccine that we use is the live. And what strain? It is what? Jarylin strain. All right. Then we have next we discussed about the measles, measles, and rubella, and it is the most common cause for the childhood rash. All right. There also the source are the cases only, the patients only. There are no carrier stage, and secondary attack rate is very high, up to 90%, and incubation period is up to 1 to 2 weeks. We had the incubation period for the mumps and the measles. For the measles it was 2 to 3 weeks, and for the mumps it is 1 to 2 weeks. Measles we have 1 to 2 weeks, and mumps we have 2 to 3 weeks. Then when talking about the measles, that is the first we have the prodromal stage. Okay, so what is that prodromal stage? That it will patient will have the fever on the 10th day. After 2 days, on the 12th day, he will have the Koplik spots, and after 2 days, that is on 14th day, he will have the rash. Now, Koplik spots, they are the characteristic, and they are white to blue spots on the buccal mucosa and near the second molar, and along with the cough and the redness of the eye. Cough and the redness of the eye is important, because whenever we have to categorize a patient as a patient of the measles, along with the complicated spots, that is a characteristic, we also have to see the patient is having the cough and the redness of eye along with the rash. So next, in the eruptive stage, from the name, that is eruption of the rash occurs on the 14th day, and the rashes are how we'll see the image, that is a dusky red rash appears behind the ears, but these are absent in case of the HIV. Now, these are the complicated spots that are present on the buccal mucosa near the second molar tooth, and they are appearing on the 12th day. On the 12th day. Diagnosis is important, that is, in measles, we get Bartholin fingality giant cell, that is, you get the intranuclear crowding and irregular nuclei within the cytoplasma, that is the Warthin fingality giant cell. Most common complication, otitis media and the bronchioli. So we have the pneumonia here in the measles. The name of the pneumonia is what? Giant cell pneumonia. That is what? Hatchett's pneumonia. Okay? Hatchett's pneumonia is common in patients who are already infected with the HIV. Now, another complication, very important one, that is subacute sclerosing panencephalitis. Then we have the vaccines. Vaccine, the strain again important here for the measles. That is a live attenuated vaccine, Edmonton Zagreb strain. And इसके अलावा we have the Schwartz vaccine and the Moreton strain. Prepared from the chick embryo and the human diploid. The most common side effect is the toxic shock syndrome. Okay, now Vaccine is given within 3 days if the after exposure. How do we give vaccine is given within the 3 days, and incubation period for the vaccine is 7 days, and for the wild strain it is about 10 days. Elimination had the strategy catch up, keep up, and the follow up. Now next we'll discuss now about the respiratory syncytial virus. Yes, so we have the respiratory syncytial virus. Now, respiratory syncytial virus have no neuraminidase and it is a chimpanzee coryza agent, most common cause of the bronchitis. Okay, most common cause of the bronchitis, that is what? That is the respiratory syncytial virus. All causes the pneumonia and the otitis media. What is the most common age that is affected in the RSV? That is in children, that is a 6 week to 6 months. All right. In the adults, the most common symptoms are the common cold with rhinorrhea, sore throat, and the cough. And for the respiratory syncytial virus, the most common precipitating factor, it is the most common precipitating factor for the acute asthma. All right. So respiratory syncytial virus is the most common cause of the bronchitis in the children. And what is the age group of the children that is affected is 6 months to this 6 week to 6 months, and precipitating factor for the acute asthma. Now, most common precipitating factor for the exacerbation of the chronic asthma and the reinfection, milder illness than cases of the primary one. In case if it presents with the recurrent infection, causes the epidemic in the winters and in the rainy season. Now, culture giant cell and the syncytial formation on the HeLa have two cell lines. And what is the treatment? Treatment is the ribavirin. Now, what are the points that are asked from the respiratory syncytial virus? It is that most common cause of bronchiolitis in the children and 6 weeks to 6 months of the age, and most common precipitating factor for the acute asthma. And we see the epidemics in the winter due to RSV. Now, next is the parainfluenza virus. Now, next one is the parainfluenza virus. Now, parainfluenza virus, that is parainfluenza type 2 crowd associated virus, more common that of the type 1. It causes the acute laryngotracheobronchiolitis in the preschool children and responsible for the epidemics. Then we have the parainfluenza type 3, that is a lower respiratory tract infection and the pneumonia. So we have the parainfluenza type 1, 2 and type 1, 2 and 3. We are all talking about the Paramyxovirus. We had two groups in the starting, ortho and the paramyxo. In the orthomyxovirus, we had the influenza type 1 to ABC. Then we have the paramyxovirus, where I'm having the parainfluenza, measles, mumps, respiratory syncytial virus. So now moving next, Newcastle's disease virus, that includes the avian paramyxovirus type 1, or in India it is called as the Rani Khet virus. Just remember the name, that Rani Khet virus is what? Avian Paramyxovirus. Alright, and it is what? Avian Paramyxovirus has the outbreak in the poultry farms and present with the pneumoencephalitis, self-limited conjunctivitis in the human. So, Newcastle's disease virus includes the avian paramyxovirus, which is also known as the Rani virus. Then we have the rubella. What is the other name for the rubella? It is also known as the German measles. Now, it belongs to the family Togaviridae, and not a myxovirus, identified by the interferons and the interference and the ecovirus. Source are the cases no carriers and provides the lifelong infected ones are infected. 40% of the females in the reproductive age group are susceptible, and 1 week before to 1 week after the appearance of the rash, the rubella is effective with 14 days incubation period. So rubella, that is also known as the German measles, and it is cases are the only source. There is no carrier. Once infected, gives immunity 1 week before to 1 week later. It gives what the infectivity period, that is for 14 days. Transmission by the droplet sexual, and rashes on the first on the face that will last for few times, then it is present with the lymphadenopathy. Now, Fortimer spots are seen, that is a pin-sized patchy on the soft palate, and the uvula starts with the onset of the rash. This is important to remember that in rubella we have Fortimer spots that are pin-sized patchy on the soft palate and the uvula. Most widely used is HAI, that is agglutination inhibition test. Then we have the another important one, that is the congenital rubella. Alright, in the first trimester, the risk is maximum. After fifth month, the risk is negligible and causes the permanent changes. Now, classical triad of the rubella is in the ear will present with the nerve deafness, that is sensory hearing loss. Then in the case of the ocular, we have the retinopathy, that is a salt and pepper retinopathy and the cataract, and cardiac defects, the patent ductus arteriosus, pulmonary arteriostenosis, and VSD. Other than this, we have the 2M, that is a microcephaly and mental retardation. So that is the triad in starting from the brain, microcephaly, mental retardation, then coming to eyes, retinopathy, and the cataract, then coming to ear, that is a hearing loss, nerve deafness, and then if the heart, it is a PDA, then PS and the VSD. Transient changes present with the hepatosplenomegaly, bone lesions, intrauterine growth retardation, thrombocytopenia with the blueberry muffin syndrome. Thrombocytopenia with the patchy, that is the blueberry muffin syndrome. Diagnosis is the IgM at the birth or persistent IgG that doesn't fall to fall dilution. Then we isolate the virus with the RT-PCR. Uh, Now, vaccination is RA23 live strain. This is also the strain that is important. Now, the classical triad we have to remember. Next, we have to remember the blueberry muffin syndrome that is seen in what rubella. Vaccination strain is RA27 by 3 live strain, prepared from the diploid cells, and we give the zero point 0.5 ml subcutaneous. Alright, and it is the females in the reproductive age. In vaccinated women, pregnancy should be avoided for 28 days or 3 months. So this is controversial, that is in vaccinated women, the pregnancy is avoided for at least 28 days. Now, this is again important. The rashes appearance in the rubella we have is how I write R, that is in the first day. Then we have on the second day, that is chicken pox. On the third day are on the smallpox. On the fourth day, that is the measles. Fifth day on the parvovirus 19, exanthum infectiosum. Sixth day HHV6 or the exanthum subitum, that is the roseola infantum. Vaccine storage, I guess 1 or 2 slides are left, then we'll cover the MCQs. So what is the vaccine storage for the polio and the measles? You must have read is in the PSM as well. So that is we use the deep freezer because in the PSM we remember it by the temperature wise that where the vaccines are stored, and the vaccines stored at the deep freezer level are the polio and the measles, and the vaccines stored at the cold part and never allowed to freeze are the DPT, typhoid, all the T1 that is a DPT, typhoid, TT, DT, and the BCG diluents. Alright, vitamin A that is at the room temperature, vitamin A is stored. So remember, deep freezer level that requires the very low temperature for the storage are the polio and the measles. Then the T1 that are stored at the cold temperature that is uh, never allowed to freeze. So it is 4 degrees Celsius. That is DPT, typhoid, TT, and DT, as well as BCG diluents. Now, vitamin A is not stored at they are stored at room temperature. Most of the vaccines can be stored up to 5 weeks between temperature 4 to 8 degree Celsius. Alright, open multiple multi-dose vials should be discarded within 1 hour if no preservative is added, and if the preservative is added within 3 hours or till the end of the sessions. We take it as a 4 hour that after opening the vial within 4 hours we have to use the vaccination. So this is the list of the vaccine that needs to be stored. Now we'll do the question answers. Yes, avian flu is due to H1N1, H3N1, H5N1 or H7N1. Easy one, that avian flu or the bird flu, where it only transmission from bird to human and there is no human to human transmission is there. What is the strain that is responsible for the avian flu? That is easy one, that is H5N1. All right, H H1N1, H1N2, H3N2, they are all this swine flu strains. Now, moving to next one, a 70-year-old woman, she refused to take the vaccine, influenza vaccine. Death happened after 1 week after pneumonia. Most common cause of the post-influenza pneumonia is staph, measles, legionella, or the CMV. So we are talking about the post-influenza secondary pneumonia. And when we talk about the post-influenza secondary pneumonia, where the most common is the secondary infection is seen post-influenza, the responsible agents are the Streptococcus pneumococci, Staph aureus, and what is H. Haemophilus influenza. So these are the three agents that are most common responsible for the post in staphylococcus, this post influenza pneumonia, the streptococcus, and the H influenza. Now, reason for the H5N1 influenza not becoming a pandemic is that man-to-man transmission is rare, no human-to-human transmission occurs, it is a less virulent, and bird-to-bird transmission is not efficient. We are talking about the avian flu, that is H5N1. So what is the reason for the H5N1 not becoming a pandemic? Now we read that in the avian flu, there was what? There was bird to human transmission, apart from the bird to bird transmission, because of it's mainly bird flu. So that is a bird to human transmission is there, but there's no human to human transmission. And this is the only reason that H5N1 avian flu influenza is not becoming a pandemic, because this is true, man-to-man transmission is rare, and the rare it is not there in fact. So that is a no human-to-human transmission is occur. Less violent, this is not true because avian flu is highly violent condition, and there is around more than 60% of the fatality rate. All right. Now, coming to the next one, outbreak of the avian flu influenza pandemic in the China in 2013 is caused due to which strain? Now, when we talk about the avian flu strains, we have H5N1, then we have H7N9, we have H7N3, H7N7, and H9N2. We mostly talk about the H5N1 strain, that is the most common responsible for the avian flu epidemics. Then we have the H7N9, N3, and 77. 79, 73, 77. Always these all other strains of the avian flu. Now, there was when there was outbreak in the China in 2013, around 130 people were affected by the avian flu and around 60 people died out of it, because I told you that around 60% mortality is there in the, it is highly virulent condition. So in the China, it was due to the H7, H9. Now, coming to the next question, new influenza vaccine includes the split viral vaccine, and neuroimmunidase, live attenuated vaccine, skilled vaccine, or the recombinant vaccine. So, it's a PGI question. More than one answer will be correct. That new influenza vaccine includes. Now, when we talk about this influenza vaccine, previously we had the traditional one that we generally use. That is the live attenuated one. And what is live and the killed? Traditional, that is a live and the kill we had. Now we are having the new vaccines which are including what will be the answer, which includes the subunit vaccine, is a neuroimmunidase. In influenza, if you remember, we had the Na and Ha antigens. Now subunit vaccine that is having neuroimmunidase, split virus vaccine, and what else? Recombinant vaccine. Recombinant vaccines. It is a split virus vaccine, recombinant vaccine, and the neuroimmunities. Live and the kill, they are previously traditional vaccines that has been used. New we will have the recombinant split and the subunit one. So true about influenza is that it is a asymptomatic cases are rare. Incubation period is 10 to 12 days. Pandemic is rare. Extra human reservoir is not seen. All the age and the sex are equally affected. So which of the following are true? Yes. So which of the following statement is true? Now, talking about the influenza, asymptomatic cases are more common than the symptomatic one. So this is false. All right. Now, incubation period, if you remember, we talked about the incubation period that is 18 to 72 hours, that is up to 3 days, the incubation period is there. So this is also false. Now, pandemic is rare. The question is saying the pandemics are rare in case of the this influenza, but we had the influenza subtypes A, B, and C, and the A1 that was the most common responsible subtype of influenza for the epidemic pandemic, and pandemics occurs after every 15 years, so that is not a rare, because pandemics are very common case of the influenza, and that too by the type A. Influenza A is only responsible for the pandemic cases. Extra human reservoir is seen. Now, not seen, sorry. So extra human reservoirs are seen in case of the animals as well as the birds. So we cannot say that extra human reservoir is not there in case of influenza. Now all the age groups and all both the sexes are equally involved in that of the influenza. So only statement E is true. Now, swine flu in 2019 is caused by the H1N1, H5N1, H3N1, or H3N3. So swine flu that was in the H1 2019, that was due to H1N1. What other strains of the swine flu? This is the avian flu. That is the H1N1, H1N2, and H3N2. Now, antigenic variants. Antigenic variation is seen in all except influenza A, B, C, or none of the above. So antigenic variation. Now we have two type of antigenic variation. One is the drift and one is the shift. Drift was the gradual changes and shift is the sudden change. Now drift and shift both are seen in the influenza A, and the shift is seen only in case of the influenza A, while drift is seen both in the influenza B and the A. C is antigenically stable, so we do not see the antigenic variant in the influenza C, and also influenza C is not seen now. All right, so that is the influenza C. It is not circulating now. Now, moving to the next one. Myxovirus includes the orthomyxovirus, influenza, measles, polio, and the HSV. Now, when we studied about the myxovirus, you remember orthomyxovirus and the Paramyxovirus. So in the orthomyxovirus, we had what? Influenza A, B, C, and the Paramyxovirus, we had what? The measles, mumps, respiratory syncytial virus. So A, B, C belongs to the myxovirus. Now coming to the next one. H5N1 is a strain of, it's an easy one, that H5N1 is nothing but what is that? Is the avian flu. Antigenic variation seen in which of the following: influenza vaccine, influenza virus, or the hepatitis virus, yellow fever, or the leptospira. Yes. So what is the answer? Antigenic variation seen in which of the following? Influenza virus, hepatitis, yellow fever, and the leptospira. So we have seen that antigenic variation, that is a drift and the shift, and we see in that case of what? Influenza virus. Easy one. And the one thing that we need to remember, and that why we see the antigenic variation in case of the influenza virus, it is due to the presence of the heme agglutinin and the neuroimmunidase presence in case of the influenza that is responsible for the antigenic variation. Now, coming to the next one, which of the following statement are true of all of the paramyxovirus? That they contain a single-strand RNA genome of the negative polarity, envelope is derived from the host cell plasma membrane, and they have the cytoplasmic site of the replication, and they enter the body by the respiratory route. The statement that is true about the paramyxovirus. Yes, so what is the answer now? Say it is more than one options. I will come to each of the options now one by one. They contain a single standard RNA genome of the negative polarity. Now they are RNA virus. We had the pneumonia for the DNA virus. That DNA is happy. That is herpes virus, hepatitis, DNA virus, adeno, polyoma, pox virus, okay, and papovirus. So they were all the DNA viruses, and which of the following is true? Now we have to say. Now they are RNA virus and of the negative sense strain. So this is true. Now in any virus, the outermost envelope is derived from the host cell, because whenever in the host cell there are the daughter virions, when they'll move out, they will take up the lipid bilayer of that of the cell, and that is the envelope. They have the cytoplasm because they are what? They are RNA virus, and RNA replicates in the cytoplasma, but DNA replicates in the nucleus. But we have the exception in that case, that is a pox virus. They enter the body by the respiratory route. This is also true in the paramyxovirus. We have the viruses that mainly infecting the children, and that is by the respiratory route. The mode of infection is acquired by the respiratory route. That is the measles we have, mumps we have, and the this respiratory syncytial viruses and all. So according to WHO, measles elimination strategy, vaccine campaigns are done in which phase? Mop up, follow up, keep up, or catch up? Yes, so WHO measles elimination program, if you remember, that was catch up, keep up, and then follow up. In the catch up, there was international level vaccination campaign to eradicate the measles. And the keep up, there are services that are being provided that the vaccination is done correctly, so that more than 95%, of the successive birth cohort is achieved. Then we have the follow up, that it is a nationwide at national level. Every 2 to 4 years, there is again vaccination campaigns to keep up with the catch up campaign at the international level. So that is the catch up. All right. So we have the catch up, we have the keep off, and then we have the follow up. Now, which of the following vaccination is not needed in 70 years elderly male? That is a measles, tetanus, hepatitis, or the typhoid one. So the vaccination is not needed. Now, in elderly mean, when we talk about the vaccination, we do not, in amongst the four one, we do not need the measles, which is mainly given. Is mainly given that is along at the 9 month around, and that is to get the seroconversion, and the possibility of acquiring the measles by that age is lowered. That is from 6 to 15 month, and prevents a balance between the optimal age for seroconversion and the probability of acquiring the measles before that age. So, which of the following is not true about the measles? That is having the high secondary attack rate. Only one serotype is there, not infection in prodromal stage, or the infection confirms the lifelong immunity. So which of the following is not true? Now it has secondary attack rate of up to 85%. So this is true. Only one serotype that is antigenically homologous. This is also true. Infection confirms one infection in case of the measles and the chickenpox. They confirms the lifelong immunity. Alright, it is not infectious in the prodromal stage. The measles is infectious in the prodromal stage, and we had what? We had the fever, then we had the Koplik spots, and what is the rash, and what were the time period? That is the 10th day, on the 12th day, and the 14th day, along with the cough and the redness of the eye. That was important to categorize for the measles. So it is infectious in the prodromal stage. Alright, and what was the incubation period for that of the measles? That was about 1 to 2 weeks. Least common complication in case of the measles is diarrhea, pneumonia, otitis media, and subacute sclerosing encephalitis. So the least common complications. Now talking about the least common and the most severe one is SSPE, that is subacute sclerosing encephalitis. That is the least common, but if it happens, then it will be the most severe complication of the measles. The most common complications are the pneumonia, the bronchopneumonia by the staph, streptococcus, and the H influenza in case of the measles. Now, coming to the next one, which is true about the measles, that survivable outside the human for the 5 days, and it carry out the source of the infection. Infection incidence is more common in the males, and secondary attack rate is 90%. Okay, so maybe which of the following is true about the measles? Now survives outside the human for 5 days. Now they are viruses. They are obligate pathogens. They won't be able to survive. That is outside one. The humans are the only reservoir. Carriers are the source of the infection. Now incidence in the more male is more common that of the females. Just a second. Now, cases are only the source of infection. There is no carrier stage for the measles. So, it is not the carrier that is the source of the infections. It is the cases that are the source of the infection. And incidence in case of the measles for the male and the females are the same. And the secondary attack rate is very high, that is up to 90%. Humans are the only reservoir. Therefore, it cannot outside the human. It cannot survive outside the human. So remember, for the measles, human are the only reservoir and cases are the only source of the infection. Incidence for the male and the female is same. Now moving next. Reservoir for the measles are the man, soil, monkey or the fomites. So we just talked about that there is no latent infection for the measles and man is the only reservoir for the infection. Measles and the cases are the only source of the infection. Two about the measles are the Koplik spots appears in the prodromal stage and the fever stops after the onset of the rash. Vaccine at the 9-month incubation period of 6 days and not diagnosed when coryza and rhinitis are absent. So which of the following is true? So which of the following statement is true? Now coming to first, when the Koplik spots appears in the prodromal stage, this is true because we remember that having the fever, then had the spots, and then the rash. And what was the sequence of the days? 10th day added to 12th day added to on the 14th day. Fever stops of the onset of the rash. Now fever and rash will gradually disappear, but fever doesn't stop after the onset of the appearance of the rash. After 3 to 4 days of the rash, the fever gradually disappears, but not just after the onset of the rash. Vaccine is given at the 9th month. This is true, and incubation is period around 10 days, and it is not diagnosed when coryza and rhinitis are absent. Now, uh, for the diagnosis, for the clinical diagnosis, it is based on the typical rash and what else the Koplik spots. Along with that, the diagnosis is infective red eye and the cough are absent. Now, a baby was given the measles vaccine at 6 months due to an outbreak in the community. Which one is correct statement regarding subsequent doses? That it is given at 9 months and given one dose as soon as possible. No dose is required, or the given at 14 to 16th month with age with booster dose. When we talked about the vaccine for the measles, we talked about that measles is given at the 9th month along with the vitamin A. Now the thing is that if the baby has already been given the vaccination at the 6th month, we again in the baby is given vaccine at the 6th month only in the cases if there is an outbreak in the community or there is any epidemic. In that case, we give at 6th month the vaccination, and again we have to give the second dose at 9th ninth month. All right, so there has to be at least 1 month gap. And if the baby has already been given the 6th month vaccination, then we'll again have to give at ninth month. Give us one dose as soon as possible. No, at least 1 month gap should be there, and no dose is required. The second dose has to be given at the ninth month. To eradicate the measles, the percentage of infant to be vaccinated is 70, 80, 85 or the 90%, 95%. So to eradicate the measles, the percentage of infant to be vaccinated is around 95%. All right. So coming to the next one. Which of the following is not true about the measles? Both active and the passive immunization gives simultaneously. Flaring up of the TB and the most infectious during the rashes causes the pneumonia and the otitis media. So which of the following is not true about the measles? So talking about the measles, measles is most infective. Like this is the rash. It is most infective between this uh, 4 days before the rash to that of the 5 days after the appearance of the rash, and which of the following that both active and the passive immunization is never given simultaneously. And what happens that measles actually suppress the cell mediated immunity and delayed type of hypersensitivity, causing the Montex test as the false negative one, and therefore resulting into the flaring of the tuberculosis. Most infectious during the rashes, this is also true, and causes the secondary bacterial infections. That is the most common complication, that is the pneumonia and the otitis media. So this is also true. So it causes the pneumonia and the otitis media. It is most infectious during the rashes and causes the flaring of the TB. Most common cause of the death in the measles is, it is what, diarrhea, it is RTI, it is a weakness, or it is SSPE. Now, when we talk about the measles, the most common cause of the death. Now, the least common and the most severe secondary infection is what is this SSP, that is subacute sclerosing encephalitis. Apart from this, when we talk about the morbidity and the mortality rate in case of the measles, the most common cause is what? It is the diarrhea. That is a secondary infection with the because the most common complication is the secondary bacterial infection causing the pneumonia and otitis media. But for the cause of the death, it is what the diarrhea, the secondary infection with the bacteria and the viruses that causes the diarrhea. Measles true is incubation period is 10 days, infectious 4 days before the rash, complicate spots are seen and all of the above. Yes, measles, the true statement is incubation period is 10 days, infectious 4 days before the rash, complicate spots are seen. Now, infectious 4 days before to 5 days of the rash, this is also true. Complicate spots are seen in the buccal mucosa and the bluish white spots are seen and pathogenic for the measles. And what is the infectious period is about? Incubation period is 10 days. This is also true. That is 1 to 2 weeks is the incubation period. So all the statements are true. Now, complicate spots seen in the measles are seen in the prodromal stage, post measles, eruptions, or all of the stages. So easy one. Now, complicate spots are seen on the 12th day. If you remember 10th day, 12th day, and the 14th day, on the 10th day, we are having the fever, then we have the spots, then we have the rash. So they appears 2 days before the rash and very characteristics for the measles. And it appears where it appears in the prodromal stage. All right. Post measles, there is a weakness, and in the eruption stage, we are having the rash. In measles, the patient is infectious 3 days before to 4 days after the onset of the rash, or 4 days before to 3 days after the onset of the rash, or 4 days before to 5 days after the onset of the rash. 5 days before to 4 days after the onset of the rash. So, which of the following is true? So, measles, the patient is infectious 4 days before to 5 days after the onset of the rash. All right, please remember. So, which of the following is wrong about the isolation of the patient? The chickenpox 2 days before to 5 days after, measles up to 3 days of the rash, mumps until the swelling subsides, and the rubella up to 7 days after the appearance of the rash. Which of the following is wrong? So we'll talk something about now when we talk about the chicken pox, the patient is infectious 2 days before to 5 days after the appearance of rash. This is true, and the patient has to be isolated. Patient has to be isolated until all the lesions are crusted and she or he becomes the non-infectious. Usually, till the about 6 days we have to isolate the patient. So this is true. Then talking about the measles, measles is infective, that is 1 week before to 2 week after the appearance of parotitis, and it has to be isolation has to be done until the swelling subsides. All right, so that is for the measles. Then we have the mumps. So that was for the mumps. Sorry. Then we have the measles. That is, measles is infectious 4 days before to 5 days after the appearance of the rash, and from the onset of the cattle stage till the third day of the rash we have to isolate. The chickenpox, until the lesions are crusted, we'll have to isolate, and that is infection is from 2 days before to after 5 days. For the mumps, it is until the swelling subsides, and 1 week before to 2 week after the appearance of the parotitis. Then we talk about the rubella. Now, rubella, that is 1 week before, 1 week after the rash, and the patient need not to be isolated because it's not that infective, except the woman is sexually active or the non-immune compromised condition, or the third trimester. So, option D. Immune therapy, immune cytopenic purpura is a thrombocytopenic purpura is a complication following each of the following vaccine, that is a DPD, OPV, MMR, typhoid, or the influenza. Yes, so ITP is a common complication. ITP is a complication of which of the following vaccine, that is a measles, mumps, and rubella. All right, chemoprophylaxis is not done for the measles, for the TB, for the diphtheria, for the conjunctivitis, or for the cholera. Now, there is no drug that is available for the that is for the measles. So, chemoprophylaxis cannot be done for the measles. Hence, vaccine prophylaxis has to be done for the measles. Please remember. Other than that, the chemoprophylaxis is done for the cholera, that we give tetracycline, and for the this diphtheria, that we give erythromycin. Then we have the plague, that also give tetracycline. Then have the influenza A, where the amantadine has to be given, and the vaccination for the chemoprophylaxis. For the diphtheria also it is erythromycin and the first dose of the vaccine. And then we have the meningococcal meningitis, where sulfadiazine has to be given for the chemoprophylaxis. All right, so we gave for the TB, diphtheria, conjunctivitis, and the cholera, but for the measles, there has been no drug, antiviral drug that is has been available. So for the chemoprophylaxis, we doesn't give, we actually give the prophylaxis by the vaccination. So we'll continue the rest of the questions in the second session in just 5 minutes. So I'll see you soon in that one.